Now, I'm going to try and get up the Q&A here, and we can start with some questions to the speakers. Toni, the first question is really for you, which is really a good question about, do your findings so far warrant a change in practice? Should we be swapping to CAD pumps and battery-powered infusers and other things, or should we just keep working with what we've got but adjust around it?
Yeah, I guess, you can hear me. I guess for us, we've decided the higher dosed ones, we definitely need to make a change. And that's why we're looking at using the battery operated pump. I mean, we haven't used one in the clinical setting, and there's not a lot of data out there for the battery operated pumps in the clinical setting, but all the data in the laboratory seems to indicate that it probably will overcome the higher viscosity solutions, the back pressures, the things like that. With the lower dosed infusers, it's less clear. I mean, I even pointed out on one slide the cefazolin and the flucloxacillins were all sort of emptying within those recommended ranges. I guess with us, with the problems we've been having with the higher dosed infusers, we've thought, well, our options are we try this new infuser that's coming out that apparently is going to overcome the high viscosities, keep watching them really carefully and use top-up doses where we need to, use the battery operated pump. I guess in general, we need to do more research overall. And the question about them going through too fast, I think that's less of an issue with us. They sometimes do go through too fast for the vancs. It was really just that it might be easier to do vanc levels if we use a battery operated pump, because maybe it'll be a little bit more uniform, because sometimes they're emptying a bit early. But yeah, we haven't really had issues as such with adverse effects or things like that. I don't know if that answered your question, but
no, look, I think that's a really good answer to the question. I guess there's a lot of psychology around it as well, isn't there, and how much that small difference in dose really impacts, given the huge variability in levels in people as well.
Yeah.
My question, I just want to ask you a question that's a bit more sociological, which is, I noticed that patients get quite focused on the infuser and what's left in the balloon and what's not and how quickly it goes through. Have you done any work around that? When you were doing this work, did you kind of get much of a sense of the patient's psyche around that?
You mean that they do watch it really closely?
Yeah, the patients get quite obsessed with it sometimes.
Oh, really? I haven't noticed that, but I'd probably have to ask the nurses that I work with, because they were doing the like the collecting of data at home. But I haven't heard that. But I haven't. No. I guess you don't want to stress them out too much. That's right. But I guess what we just tell them, I guess our general counselling point is not to be too overly stressed about it, but if after a couple of hours the balloon's not getting much smaller in size, just to let us know. And then most of the watching of it at the moment is our nurses, and they're really good at it. Because we did that quality project over a year, they're now looking at the residuals every time they visit, and they document it, which is really great, which has enabled me to go through all the notes and look to see for this particular audit that I'm doing. So it's really the nurses that are looking at it really closely. But yeah, I just pointed out there that we should still be asking the patients to let us know earlier in the day if there's some real issues, like the ones when we remove them full or half full, that type of thing.
Okay, excellent. Thank you. Yeah, it's really, really interesting work, and I think it's kind of opened up a whole area that we just need to keep understanding more of. Now, I'm just looking at the second question. I think that's more of a comment, Kim, on your work and some of the challenges with groups with using COPAT. Yeah, I might ask you a question while you're here, which is really, I guess in all of your work, if you were to kind of put two lines on it, who are the people that you think benefited the most from the COPAT? Was it, just the cotrimoxazole group, or was it, a particular subpopulation of patients, with comorbidities or other things that, if we could only put a select group on COPAT, who would it be?
Yeah, that's a great question, Ben. And clearly there was a winner in terms of a problematic HPOA. So Bactrim, within 5 days, if you didn't, you'd either have a problem, and if you kind of got over that, then you may have been okay. But so I guess if I had to pick, two patient groups, those that are on Bactrim, but it also depends on risk factors and, disease burden. So obviously the higher risk cohort, those with lots of comorbidities, those who are on a lot of medications and are being started on a HBOA, and the riskier ones such as Bactrim and kind of the other, the rifamycins, azithromycins. So the high HBOAs and those patients with high risk factors definitely would need close monitoring in the outpatient space. Clinics can take this on, but the frequency of reviews that would need to be done could put a lot of pressures on clinic wait lists. And so COPAT can provide a lot of support for clinic in that respect.
Thanks. And just one more follow-up question on that, which was really just, you commented that some of the reactions occurred early. Do you think there's an optimal duration of follow-up for patients? Like if somebody's been cruising for the first few weeks, can we move them off a COPAT program, or should we keep them on?
Sorry, yes, that was the point I was trying to get towards the end. So as we further progressed with the program, we identified that the modelling could be changed and that there were patients who, once they were stable, could be de-escalated to a lower monitoring, regimen, and especially patients on lower risk HBOA, such as clindamycin, and those with lower disease burden and lower risk factors. You could review them a lot less frequently, and that would improve the clinic capacity.
Thanks so much. Now we're going to keep moving through. And Matt, there's a couple of questions for you there about the subcutaneous infusion. Have you spotted them?
Yes, I've had a look. I'm not aware of too much paediatric data that's around, and all the stuff I've seen is about sort of shorter intermittent infusions rather than prolonged or 24-hour infusions, but I don't really see why they couldn't be considered, as long as you're sort of keeping in mind that there might be some concentration dependent issues associated with skin irritation. So, and with regard to using the choice was either there were no oral options for these patients, so particularly with our ertapenem data. So the choice was either sending them out with IV intermittent infusion or employing the subcutaneous route, which was, a lot more convenient for and resulted in quicker discharge.
And I think there's a comment there about 24-hour continuous subcutaneous administration as well. I don't know if you've ever thought of that.
Yeah, again, it's all been sort of shorter intermittent infusions rather than, or there's also some published reports of pushes, sort of subcutaneous injection rather than a subcutaneous intermittent infusion. I haven't seen anything with regard to 24-hour infusions, but again, that's where I'm saying that I guess if you're going to put more in an infusion, then you might get concentration related adverse events associated with skin necrosis or skin irritation, if you like. Skin necrosis obviously would be bad, but I'm talking more about skin irritation. If you start increasing the concentrations of what's in the bag, there's probably no reason why lower doses like a gram of ceftriaxone or whatever couldn't be given subcutaneously. But do you need to if you can give a intermittent infusion? It's pragmatic approaches, really, isn't it?
And just one bigger picture question for you. I'm really, I think your comment about the risk benefit is really important in this setting. And
yes,
I don't question, but do you think we kind of sometimes underestimate the risk and the burden of the IV access we use, the IV cannula, the PICC lines and things like that? And you know, I don't know about your program, but I've seen that guidance about not using PICC lines in patients, you know, with near end stage renal failure, but we don't really adhere to that. And, you know, seeing what your data you present, I think we should be trying to avoid it more often when there are other options.
Yes, I agree. And, you know, there's a lot of interest around other sorts of IV access. You know, is it better to start using midlines rather than PICCs and vice versa? You know, I think sort of particularly in CKD patients and, you know, avoiding Broviacs and other sort of things, you're really, I think it's a bit of a no-brainer for certain patients, actually. And I think there's enough data to show that, you know, if someone just needs parenteral therapy primarily because there isn't an oral option, then this is a really quite a suitable thing to do.
Yeah, thank you. Now, Kim, there's just a couple of questions there about the cost analysis. I'll let you have a quick look at them and a question about compliance assessment before patients come on.
So there's a cost savings question. So with the cost save, was that inclusive of additional staff, time cost, substitution, cost of the pharmacist, other team members doing non-IV work? No, so the cost analysis that we did, we modelled it very similar to that which was done by the paper by Marks, and so it was the cost savings was through IV treatment days saved. So for those patients who had severe infections traditionally treated with long courses of 4 to 6 weeks of IV antibiotics, the IV treatment day saved was their length of stay on COPAT to a total of 28 weeks. And that worked out to be, you know, just over 300 IV treatment days saved and the costs associated with that. So it was the cost savings was through HITH bed days saved, as well as PICC insertion and antibiotic infusion costs. So that was what the cost modelling is around, but clearly a broader economic evaluation is required to fully realise the economic benefits of the service. Is there
We've just about whether there's any compliance assessment or any concerns with that before patients come onto the program.
Yeah, that's a great point. We actually didn't assess medication. Well, Tia, so the nurse kind of interviewed the patient and kind of assessed their kind of adherence and educated them on the program, and Tia would have gauged quite well whether they were going to be adherent with their medication. We didn't really assess medication adherence as one of the outcomes of the study, but it probably makes sense that with the high frequency monitoring and the frequent health assessments, that adherence would improve and that the benefits of our service would be from medication adherence, increased medication adherence. There were a couple of patients that we had to exclude because, actually there were a few patients that were discharged because they were non-compliant with monitoring requirements. So, if they missed a few phone calls or, if they missed a few tests and they weren't compliant with the requirements, we did move them off the service.
All right, thank you so much. That's great. Now we're coming up to time here, and I better finish on time, otherwise I won't get invited back again. So look, I'd just like to thank the three speakers. Kim, Matt and Toni, they were really fantastic presentations, and you're all kind of really, pushing the boundaries of what we do in HITH and OPAT and really looking at how we can improve what we do and, how we can improve in terms of the way we treat patients and the outcomes we get from them and the way we use our therapy. So it's really fantastic to see. Just a few closing announcements, one of which is to highlight some further great upcoming events for CRE Respond. You can look at their website, which has them all on there, but there is a dosing seminar on the 26th of October. There is an NTMC symposium on the 16th and 17th of November. And go to the website and have a look at them, and all of the presentations are on YouTube. So give the CRE Respond YouTube channel some clicks. Once again, I'd really like to thank the sponsors, Pfizer and Gilead, for their support of this series. Speakers, as I've said, fantastic talks. Thank you for your time. And to the audience here and online, thanks for listening, and thanks for participating in the discussion as well. And we'll see you for the next seminar.